All
Well,
right.
hello. Well, thank you for that introduction, Rachel. As she indicated, I am Merrilee Gober, and the only thing I want to add to that is my disclosure. I have no financial interest in this topic today, but I am a volunteer advocate in the maternal infant space, really out of embarrassment. I just did not know what I did not know. And I believe we all need to help one another in closing this gap in knowledge so that we can give our mothers and babies the care that they need so that we can support them to be successful in their breastfeeding journey. So, our learning objectives today are the health benefits of breastfeeding for the infant and mother, how to assess, anticipate, and address the clinical lactation care needs of maternal patients to optimize success for that breastfeeding dyad. And the second part of my presentation will be connecting you with resources. This is a chart. It's just a sampling of research that we have with regard to the child illness and disease risk reduction that's associated with breastfeeding, and that is compared to formula fed babies. So we can see that breastfeeding really wins out in a lot of areas. We've got so many benefits that are associated with breastfeeding. And having a chart like this is really helpful for families to see demonstrative numbers that what they're doing to help their baby get off to the best start really is with breastfeeding. But I don't want to ignore colostrum. Colostrum is really important. It's that first milk before the mother's other milk comes in. She starts producing it during pregnancy and will produce it for several days after delivery. It's thicker than mother's milk, so it's easier to help that baby learn how to suck, swallow, and breathe until that thinner milk comes in. It's a great way to get him off to a good start. It is bundled with all kinds of immune factors, protein, sugars, and fat, gives them a lot of good calories and a lot of good immune factors. And animal studies show to us that if we don't give that baby colostrum if in the animal studies, then the intestines are actually maturing differently. We also know from studies on mice that if they are only given mature milk and never given any colostrum, that it actually stunts their growth. They will have impaired growth and systemic inflammation. So there's so much more we don't yet know about colostrum, but we need to have a healthy respect for it and do everything that we can to make sure that that baby's first feed is their mother's milk, is their mother's colostrum. Um, More benefits for the child for the breastfeeding is associated with a decrease in child neglect as that child ages. It's just lending credence to the fact that we all innately know that that bonding that that mother and child create with breastfeeding is so important. Um, we also have benefits for the mother. As you can see, these reduced risk reductions for various illnesses and diseases aren't quite as robust as what we see for the infant, but nonetheless, they're still there. They still outperform formula feeding mothers. And it may be very important to a mother who has a family history of one of these issues. And it might be the convincing factor that she needs to know to convince her that breastfeeding is what she wants to do. Um, I will note that the research shows that diabetes has a protective effect for 10 years after lactation is ended, whereas all the others have that benefit through life. But it is a limited protection with diabetes for 10 years. A risk reduction also in stroke for those mothers if they have breastfed. And this study has postmenopausal women who entered this study, and then they tracked these women throughout the duration of their lives. This study looked at women who had all had at least one child, and it also contained ischemic as well as hemorrhagic stroke. included in the study. And as you can see, with the disparities that we have, it is so important that our Black women know that they really were the winners in this. The Black women who had breastfed had a 48% reduction in their risk of having a stroke if they had done any breastfeeding. So great study. I really commend it to you to share it with your families. Breastfeeding also confers a benefit to that mother right after delivery with better uterine tone, and it's associated with a decreased risk of postpartum depression when that mother intends to breastfeed and that breastfeeding experience is successful. If you're doing advocacy with policymakers, legislators, or people in the department of your community health or public health, they always have to know numbers. And so this is great data to be able to share with them that we do have dollar cost savings when we've got babies breastfeeding versus formula feeding. That if they breastfeed exclusively for the first 3 months of life, they save at least $750 in healthcare costs over their first year of life. And that's looking at respiratory illnesses, ear infections, and GI disturbances. So breastfed babies, I've had a pediatrician tell me that she knows immediately when the babies come in for their 1-year checkup, whether they were a breastfed baby or a formula fed baby, just based on the thickness of the chart. Wanted you to see too that breastfeeding is something that our babies instinctively want to do. And if you have a delivery with a baby with something similar to this, wanted you to include it as a differential diagnosis. This baby was very eager to breastfeed and couldn't wait to do it and was sucking on her fingers before delivery, but happy to know that these blisters resolved on their own by day 8 without any intervention. So how are you all doing in South Carolina with your breastfeeding? The latest breastfeeding data we have from the CDC is their 2022 breastfeeding report card. And it shows state by state, including Puerto Rico and DC, so there are 52 in their tally. You've got an initiation rate, you've got 80% of your moms initiating breastfeeding, which gives you a ranking of 39 out of the 52. And the duration rates, your mothers, almost 20% are exclusively breastfeeding to 6 months. And South Carolina for that ranking is 48th. So definitely there's room for improvement. Nationally, want you to also know that we've got studies showing that fewer than half of our moms nationally are making it to their personal breastfeeding goals. So we are not doing what we can to help our mothers be successful. We need to be doing more. And how do we do more? Focusing on the maternal aspect of care, I believe that starts with the very first OB visit at that OB workup. We've got to shift from asking the question, do you plan to breastfeed or bottle feed? No, no, no. From now on, we really do need to be asking these moms open-ended questions, such as, have you heard anything about breastfeeding? Or tell me what you know about breastfeeding. That's going to elicit from them any anxiety or concerns that they have, or any family members who have had problems that concern them. And that will go a long way to opening up the dialogue, to encouraging them to be able to breastfeed. You also are going to learn so much about that mom with that medical history and that physical exam. And I got this side, put everything together because I want you to compare in your mind after you've taken that medical history and after you've done that physical exam, think about whether she has any of these issues that may present an impediment to breastfeeding and being successful at breastfeeding. Now, I do have hypoplasia in red. We'll talk about that in a moment. That, to me, is a red flag. All of these other issues would be yellow flags. and not necessarily going to be an impediment, but could be an impediment. And certainly, if a mother has more than one of these issues, you really do need to be considering whether or not this mother could benefit from a prenatal clinical assessment with an IBCLC to help her have a plan in place that if it does become an impediment, they know what they're going to do to maximize and optimize her chances of being successful. Now, on the right-hand side with the breast assessment, I have in green nipple issues. Yes, you want to know if a mother has flat or inverted nipples, accessory nipples, but those don't need any intervention prenatally at all. That is something that would be addressed after delivery. And also in green here at the bottom, you do want to see breast changes while that mother goes through her pregnancy. You want to see those breasts enlarge. What you want to see is something like this. This is normal development of a mother during pregnancy and postpartum. This is healthy breast tissue. This is the hypoplasia that I wanted to share with you. These mothers, their breasts are usually farther spaced apart, and the breasts are more tubular shaped. Most of the time, these breasts have insufficient glandular tissue. Most of the time, these women will have trouble successfully exclusively breastfeeding. And these mothers need to be aware of this prenatally. They need to have a plan in place. They need to have a change of thought of what success is going to look like for them so that we can avoid that postpartum depression. And what success may look like for them is something like this, where they do continue to feed that baby at the breast, but they have supplementation of either formula or donor milk going along with that breastfeeding sessions. I wanted you to also see what an inverted nipple looks like. Again, we do nothing for this prenatally, but postnatally, she may end up needing a little bit of help with a lactation consultant to get them off on the right track. Sometimes either with inverted nipples, flat nipples, or even cracked nipples later on, a lactation consultant may determine after an evaluation that it would be helpful for a mother on a short-term basis to use a nipple shield. But I want you to know that nipple shields almost always have the potential to decrease milk supply. So it is not a decision that anyone should just be making lightly. There are hospitals that even have protocols in place that only an IBCLC is allowed to dispense nipple shields, that RNs are not allowed to do that. So it is a cautiously made decision that it should not just be made quickly. It does need a full evaluation before a nipple shield is used. Transitioning now to labor and delivery and that birth of that baby. We need to know that that first hour is so important for that mother and baby's breastfeeding relationship to get off to a good start. And also the first 2 weeks, especially if a mom and baby are separated. If that baby is in the NICU, research tells us that we've got 2 weeks to get that mother to full volume so that she will be adequately able to feed that baby for the duration of that child's needs for nutrition from the breast. If we don't get her to 500 cc's in that first 2 weeks, the research shows that we won't be able to get her to full volume. So keep those hours in mind and those first 2 weeks in mind as being very important for that dyad. The skin to skin in that first hour of life, we've got data that tells us that if we keep them skin to skin, they're both healthy, everything's going fine, that skin to skin will increase the breastfeeding duration by a mean of 64 days. We also have research showing us that if we delay the bath by 12 hours, that also helps promote the exclusive breastfeeding while that mom and baby are in the hospital. The Academy of Breastfeeding Medicine has recently updated their protocol with regard to hospital care, and their current recommendation is that the baby should not be bathed for the first 24 hours. And they also recommend that the routine medical care of eye ointment, vitamin K, etc., those medicines should also be delayed by at least that first hour until we've had one successful breastfeeding. So the meta-analysis on skin to skin is impressive and helpful to know, to share. These babies do have improved vital signs being there with their mom, and it reduces the risk of neonatal hypoglycemia. So for our mothers who have diabetes or gestational diabetes, it does reduce the risk of their needing other care. Important for that mom and baby. We know that a happy, content baby is also expending fewer calories. So it helps them, it may help them to maintain their weight. Medical interventions during labor and delivery, we know, are very common, and we just need to recognize that if we have had medical interventions with that mom and baby, we may be affecting that breastfeeding relationship, and they may need a little extra support at the time of delivery with that first hour. I wanted to draw your attention particularly to the IV fluid intake. If a mom within 3 hours of delivery, if that mother received more than 1,200 cc's of IV fluids, I would highly recommend that you somehow note that in the record where it will be easy for the pediatric team to see, because if that baby does lose weight and that pediatrician is considering supplementation, it will be something that he or she will want to consider in their analysis as to whether that is true weight loss or perhaps was just this infant diuresing and maybe doesn't need to have supplementation. Again, protecting against breastfeeding sabotage while the mother and baby are in the hospital is really important. We need to help educate our mothers that we should be avoiding pacifiers for that baby. Mothers want to avoid antihistamines throughout their duration of breastfeeding because that will decrease their milk supply. And we need to reassure mothers that there's a wide variation of normal with breastfeeding. Anywhere between 4 and 13 feeds a day. Usually it will be around 8. And a breastfeed session can last either 12 minutes if you've got a really quick feeder, or as long as 67 minutes and still be within a normal range. If there are concerns with these babies on the outliers of each of these areas, then we'll highly recommend that an IBCLC be brought in early on to evaluate this baby and the mother to see if there's any intervention that needs to be made. But moms need to understand that between 1 and 6 months of age, if they're a breastfed baby, their intake is much less. It's much different from formula. A breastfed baby will take 750 to 900 cc's a day. And as you can see, the volume for a formula-fed baby is vastly more. That feed that a breastfed baby takes is generally about 3 ounces per feeding, which is really only about 1.5 ounces out of each breast. So that makes a huge difference if moms understand that their volume that's expected for them to produce is way less than what a baby is taking out of a bottle with formula. Avoiding supplementation in the hospital if we can. Now, admittedly, that is not an OB decision. That is a pediatric decision. But there are things that you all can do to help those families avoid that supplementation. And if you are going in to see a mother on day 1 and you learn when you're in there doing your assessment that that mom is struggling with breastfeeding, don't delay. Get her a consult, get that baby evaluated, get that mom evaluated, and help them both try to avoid the need for supplementation. Because supplementation, not only do we know from the research, may have a detrimental effect on the duration of breastfeeding, but we also know from research that even just a small amount of formula in a breastfed baby is going to change his normal microbiota to the pattern of infants who are fed only formula. We don't know the long-term effects of this, but it's enough that it does. We know there's a difference, and we know that the GI, that the gut of babies affects autoimmune pathology, affects allergies. And so long term, it's just better if we can, if it's possible, to avoid that supplementation. And right now, according to the breastfeeding report card by the CDC, South Carolina ranks 41 out of 52. So we do know that there is room for improvement in South Carolina to help our moms and babies be able to avoid supplementation. The best way to avoid supplementation is to make sure that that mother and baby are staying together. And you can help with that in the OB arena. You can make sure that she's educated, that the studies show that sending the baby out during the night does not really help her sleep better. It just doesn't. And that when that baby is there with her constantly, she will be in tune and in cue to when that baby is ready to feed before that baby gets anxious and upset. We want to be feeding that baby when that baby starts rooting or sucking on his hand. We don't want a screaming baby losing calories. We want that mother there paying attention to that baby so that they can feed early and often. And as an OB, from the maternal aspect of care of our moms and babies, you as the OB clinician, the midwife, you need to be thinking about separation. If there is an unexpected separation and that baby ends up in NICU, that mother is going to be traumatized. She is not going to be thinking clearly. She needs you to help her. So it's very important that you as the OB clinician are helping her to make sure that she is pumping at least 5 to 8 times every 24 hours, and that she is pumping at least one time during the night. And actually, the latest research shows that one time during the night should be sufficient. So you want her to get up once to pump. And you want to make sure that she is set when she goes home. You want to ask her, does she already have an electric pump at home? If not, please do not discharge her. Make sure that she has a pump, an electric pump in hand, either at home waiting for her or in her hand to go home with at discharge. There are some hospitals who have really good working relationships with their WIC offices. And this is an opportunity, if your hospital doesn't already have that in place, perhaps reach out to your local WIC offices to see if they would be willing to have their peer counselors come over with pumps when you have babies who need those pumps, or moms who need those pumps as well, for your Medicaid moms. That great use of the WIC peer counselors and their pumps. And no mom should be sent home without being ready to feed that baby and produce milk for her baby. Again, that mom has to reach full potential by 2 weeks. And if we're not having her at full volume at 2 weeks, that breast is just not going to be able to produce enough for that duration of that baby needing breast milk. Your job is not over once that mother has been discharged to home. You really need to be on the lookout for those phone calls when she says something isn't quite right. You don't want moms ending up with situations like this. If they call and say something just doesn't feel quite right with one of those breasts, you want to do a timely assessment and intervene before you end up with situations like this. And either she needs to be coming in to see the OB clinician, or get her quickly an appointment to see an international board certified lactation consultant so that they can get a plan in place to avoid these situations. So at this point, we will take a break to have some discussion, and then we'll come back and talk about resources